motility of the gut, and particularly the functions and motility of the large intestine we are going to discuss over here. So starting from the principal functions of the colon. As we know that colon is majorly there for the absorption of water and electrolytes from the chyme to form solid feces. So it needs enough time for the chyme to be present inside the colon before that it becomes solid feces. And the second important function of the colon is to provide storage of the fecal matter until it is expelled from outside, which is majorly the function of distal half of the colon, whereas absorption was majorly the function of the proximal half of the colon. Now, keeping in mind the major functions of the colon, the motility of the colon is going to correspond to these functions, including the segmental contractions, are also called as haustrations in the large intestine for the mixing purpose, peristalsis for the forward progression as well as providing little bit the mixing of the contents, and lastly a specialized type of peristalsis only seen in the colon called as mass movement. So starting from over here, as we saw in the small intestine, the mechanism of peristalsis is the same. There is going to be constriction behind the food bolus and relaxation ahead, resulting in forward propulsion of the bolus. Whereas segmental contractions mechanism is almost the same, where the contraction occurs at regular intervals and the rest of the points are relaxed, and then the cycle is repeated at different points, resulting in mixing of the chyme in the neighboring segments. Although there is going to be a little bit variation as compared to the small intestine that we will be discussing in a while. Again, you can appreciate the segmental contractions and the areas of contraction being replaced by the areas of relaxation alternatively in this video. Segmental contractions are local intermittent contractions. Local means caused by the local basic electrical rhythm of that part. Intermittent means coming and going. Segmental contractions of about 2.5 centimeter area that occurs every few centimeter at regular intervals every 5 to 30 seconds. And that frequency is going to be decides the rate of basic electrical rhythm in the colon. Later, new contraction rings will appear in other points in the gut, and that will ultimately result in chopping and shearing of the content. Segmental contractions in the large gut are called as Haustrations because as compared to the small intestine, there is another thing that happens along with these local intermittent contractions, which is the presence of contraction of the longitudinal muscles as in addition to the contraction of the circular smooth muscles. The circular smooth muscles lead to localized constrictions, whereas contraction of the longitudinal muscles or the tinea coli leads to the bulging of the non-contracted areas, which appear as sac-like bulges called Haustrations then. So basic electrical rhythm of the local myenteric plexus decides the rate of the segmental contractions in the large intestine as well. And if based upon only the localized segmental contractions, it may move the chyme from the ileocecal valve to the end of the colon in about 8 to 15 hours, which is further enhanced by the peristaltic movement, which is designed to move the chyme from one end of the colon to the other end by its forward propulsion till the end of the colon. The stimulus for propulsive movement or peristalsis is same as that occurred in the small intestine, including distension, some irritation or parasympathetic discharge, which leads to the polarized response of the myenteric plexus, that is a contractile ring behind the bolus and a relaxation in front of the bolus. The contractile ring moves forward towards the anal direction. There is receptive relaxation ahead of it, resulting in forward propulsion of the chyme. This forward propulsion towards the anal direction is known as law of the gut, and it is in anal direction because of the polarity of the myenteric plexus. The propulsive movement are going to mostly start in the transverse colon, 2 to 3 centimeter behind the colon, and you can see there is relaxation ahead of the bolus, and sometimes 20 centimeter of the colon distal to the contractile ring is going to lose its Haustrations rather than contract as a unit, resulting in en masse movement of large amount of fecal material towards the anal direction. Previously, we discussed the propulsive peristaltic movement, constriction behind and relaxation ahead. Here you can see there is a modification, constriction behind or relaxation ahead followed by en masse large area of the colon contracting, thus propulsing a large amount of fecal material towards the anal and rectus. This is much forceful and stays for about 30 seconds followed by relaxation for another 2 to 3 minutes, where a new contractile ring will appear and ultimately the fool will be moved toward the fecal material will be moved to the rectum, resulting in rectal distension, which is a precursor for defecation. In case of some excessive irritation like seen in ulcerative colitis, this peristaltic activity will be much intense and much frequent, resulting in excessive diarrhea. Now, the specialized type of peristalsis in colon is specialized to call as mass movement. This is a modified type of peristalsis, initiates in the transverse colon. 1 to 3 times each day it will occur, especially after taking a meal and most likely after the breakfast. It is a series of mass movement that is going to stay for about 10 to 20 minutes, resulting in rapid movement of the fecus into the rectum to initiate defecation. And the mechanism is this that we just discussed. This is the mechanism of mass movement, in which a huge part of the colon ahead of the stimulus is going to contract as a unit, resulting in en masse movement of the fecal material into the rectum, which is the precursor for defecation reflex. Now, normally the rectum is kept empty of the feces, otherwise the defecation reflex would be initiated every time even a small amount of the fecal material enters the rectum. Now, how this anus is kept empty of the feces, the reason is multifold as in front of you. The tonic constriction of the internal and external anal sphincter until there is a stimulus for their relaxation. The puborectalis sling, which maintains this anatomy, and a degree of about 90 degrees between the anorectal junction, that makes it possible to keep the anus empty of the feces all the time until you strain or there is defecation reflex. The angle is abolished, the puborectalis ring is relaxed, and the sphincters, internal and external, they are opened up. The pelvic floor, it descends down, and this is followed by the movement of the feces from rectum into the anus. So, the continuous dribbling through the anus is avoided by the continuous tonic constriction of the internal as well as the external anal sphincter. Now, what is internal anal sphincter? This is the thickening of the circular smooth muscles inside the anus, whereas the external anal sphincter, this is formed by the striated voluntary muscle surrounding the internal sphincter, and this is under the voluntary control, that is pudendal nerve, whereas internal anal sphincter is under the autonomic nervous system modulation. Now, the most important defecation reflex, this is initiated by the rectal distension, which leads to 2 types of defecation reflexes, one intrinsic myenteric and the other parasympathetic defecation reflex, which result in defecation. One by one, we will look into the details of this intrinsic and parasympathetic distension reflex, starting from the intrinsic myenteric reflex. The myenteric plexus, in response to the rectal distension, the rectal distension is the stimulus for both these reflexes. what does the myenteric plexus does in response to the rectal distension? It increases the rate and strength of the peristalsis in the descending colon, sigmoid colon and rectum, propulsing the fecus towards the anus. Along with it relaxes the internal anal sphincters by using the inhibitory myenteric plexus. And if the external anal sphincter is voluntarily relaxed, the defecation can occur. But this is a very weak reflex, and alone it may not result in complete defecation. Rather, it is potentiated further by the parasympathetic defecation reflex. Again, the stimulus is rectal distension. The message this time is not only sent to the myenteric colon, plexus of the colon, but also to the sacral segment of the spinal cord, in which the defecation reflex is going to be integrated. The efferent nerves here are the parasympathetic nerves via the pelvic nerves. What are these parasympathetic outflow going to do? Number one, again increase the rate of peristalsis in the descending sigmoid and rectum, propulsing the fecus towards the anus. Number two, relaxation of internal anal sphincter. Number three, if the external anal sphincter relaxes voluntarily, the defecation will occur. Now, this happened because of the myenteric discharge. This happened because of the parasympathetic discharge, but the relaxation of external anal sphincter is going to occur voluntarily via the pudendal nerve, which is a somatic nerve supplying the skeletal muscle fibers of the external anal sphincter. Also, voluntarily, the defecation can be facilitated by, for example, taking a deep breath, closure of the glottis, which will help in building up intra-abdominal pressure, Valsalva maneuver, as you can say, abdominal vasculature contraction, and relaxation of the pelvic floor. These are the accessory features which can aid defecation. Now, a subcomponent of this defecation reflex is the recto-sphincteric reflex. As the rectum distends, because of the myenteric reflex, the internal anal sphincter is automatically relaxed. This is known as recto-sphincteric reflex. Now that you know the normal physiology of the defecation reflex, can you appreciate the effect of the injury to the spinal cord on the defecation reflex? Before we discuss that, let's have a look at this. This is showing the recto-sphincteric reflex. As the rectal distension increases, the internal anal sphincter tone decreases and the external anal sphincter tone, it increases. This tone of external anal sphincter can be decreased voluntarily by the discharge of the pudendal nerve and relaxation of the external anal sphincter, but voluntarily you can inhibit up to a limit. If the rectal distension occurs greater than this mark, the external anal sphincter will also be automatically inhibited and its pressure will be overcome and the defecation will occur. So up to a limit, the recto-sphincteric reflex can inhibit the internal anal sphincter, and after that limit, the external anal sphincter will also be overcome. And the pressures are in front of you at which this is occurring. Now, the effect of spinal cord injury on the defecation. The impact of spinal cord injury on the defecation will vary depending upon the injury occurred at the sacral level or above the sacral level. So, if lesion occurs above the sacral segment, it will be an upper motor neuron type of an injury, where the injury occurred above the cauda equina or the sacral segment of the spinal cord. Now, in this case, the intrinsic myenteric reflex of defecation is there, which is weak. Also, the reflex component from the sacral segments of spinal cord is also there. The only problem is its communication with the upper part of the nervous system. So, what will happen? The person will lose the voluntary control, will not be able to voluntarily relax the external anal sphincter or increase its abdominal pressure. There will be anorectal synergy. When the patient will try to strain or cause rectal contraction, there will rather be increase in the external anal sphincter tone, as we saw in the previous image. this synergy will lead to a specific, A synergy will lead to specific external anal sphincter, and the reflex and the voluntary action on the defecation will be lost. Rather, the reflex defecation will still be intact, that is intrinsic, as well as the sacral segment of spinal cord can initiate the parasympathetic defecation reflex. For example, in case of mucosal stimulation, that can be by the rectal distension itself, or if imposed externally, for example, by digital manipulation, inserting a suppository or providing enema. And these mechanisms can be used for management of this type of the patient or injury to the spinal cord, where for example, enema during rectal distension can result in the sacral segment reflex and complete defecation. Although the patient will still be not having a voluntary automatic defecation, rather dependent upon some external stimulation like digital manipulation or enema for the complete defecation. In comparison, if the injury occurs at the sacral segment of the spinal cord, that is low motor neuron type injury to the sacral segment, now the reflex component of defecation will be lost. Only what would be there would be the presence of the intrinsic myenteric reflex, which will be insufficient to bring about the defecation. Now the patient will have a flexed bowel, no reflex response to even increased intra-abdominal pressure or straining, loss of parasympathetic control, and rather the fecal content will keep on accumulating in the rectum until the internal and external sphincter tone is which is also lost, and the patient will present with rather fecal incontinence, continuous dribbling of the fecal content from the rectum and anum to the outside. And in case of any increased abdominal pressure like done during Valsalva maneuver, coughing or something like that, that patient may suffer from again fecal incontinence. So to avoid this, these patients are managed by keeping their rectum empty, and this is done by manual evacuation, abdominal massages, or frequent emptying to avoid overflow incontinence. So to quickly revise, if the damage was at the sacral segment of the spinal cord, the reflex component was lost and the result was incontinence. There was no tone of the muscles and continuous dribbling of the fecal material. And if above the sacral segment, the reflex component was intact and that could be used to initiate defecation, although the voluntary control was lost and the facilitation by straining was lost. So the management is by either enema or digital evacuation. Now my next question is, can defecation be initiated voluntarily and how? Yes. Many a times by abdominal muscle contraction and lowering the pelvic floor, that is by straining, the rectum can be distended, which can lead to activation of the recto-sphincteric reflex and ultimately defecation, although it may not be successful every time. Automatic defecation is a concept in which the control to defecation is lost, for example in infants or in case of spinal cord injury. Now, how much time for this motility to occur in different segments of the spinal cord depends upon the motility patterns. So it takes about 6 hours to move the fluid from cecum to the throughout the ascending colon. Throughout the transverse colon 9 hours, throughout the descending colon it takes about 12 hours, and overall this is approximately 72 hours from ingestion till the defecation. Another thing, you can see the comparison of the basic electrical rhythm in initial segments of the colon is about 2 per minute and sigmoid colon has 6 per minute. And the chyme on average that enters the initial segments of the colon every day is 1000 to 2000 ml, whereas the feces is approximately 200 ml solid and rest of it is taken absorbed making it from fluid to mush to semi-mush to semi-solid and ultimately solid in the form of feces. So that's all about the motility of the large colon. Thank you. Large intestine or colon, I mean. All the best.